see you this picture dealing with the first anatomic theater in the world and the Aula Magna dedicated to Galileo Galilei in our old university. So my talk today is about the serological test, and I'd like to start why we have to use serological tests. We will move on the types of serological tests, both laboratory-based and point of care, the target of the assay, something about the importance of antibody kinetics, and what about the performances of the assays and the possible roadmap towards a harmonization, and finally, the testing strategies to be used in real practice, clinical practice, and final something about the humoral and cellular immunity. But first of all, I like to say you that we have to use the right test at the right time. And regarding laboratory medicine, molecular testing is for sure today the preferred method for the diagnosis of coronavirus disease. But serological tests play a relevant role, and I will deal with the role later on in my talk. And finally, many laboratory tests are essential to better understand the disease severity and for prognostication, and are clinical chemistry tests, hematological, coagulation, and enzyme that are very important. So, why we have to use a serological test? First of all, to improve our knowledge of an immune response to this new virus. Second, to better define and monitor the extent of virus spread in the population. Third, to screen particular subpopulation and to identify disease prevalence, for example, in healthcare workers for recovery and better understanding past exposure. To characterize efficacy of containment measures at the local and global level, the so-called lockdown. But also to screen convalescent sera for both therapeutic and prophylactic use, very important issue. To eventually combine molecular results for a more accurate diagnosis, and this is particularly in some difficult patients, to allow the diagnosis for later stages of infection, and in particular when the virus has been already eliminated. And finally, to identify individuals who have been infected but suffered only minor symptoms or did not seek medical attention. So many reasons to use serological tests. And which type of test can we use? We have two very common tests, point of care, that are generally lateral flow devices detecting IgG or IgG and IgM antibodies, or total antibody in different types of sample, whole blood, serum, plasma, and even saliva. Second types are laboratory-based tests, ELISA and/or chemiluminescent assays, which may detect IgG, IgM, and eventually IgA specific antibody, separately or combined as a total antibody. And finally, we have the so-called neutralizing antibody that are very, very useful to determine the functional ability of antibodies to prevent infection of virus in vitro. And there are two types of virus neutralization tests or pseudovirus neutralization tests, which are much more complicated. In this slide, you can see some advantages and disadvantages of both point of care and laboratory-based tests. Point of care, the advantage, less invasive because they commonly use capillary samples. They have a shorter analytical time, are easily implemented, but they have some disadvantage. The interpretation is very subjective. The threshold is fixed, and there is an analytical uncertainty, particularly around the gray zone. The laboratory-based present many advantages. Usually they should be qualitative or better quantitative results. They use venous sampling. They have high throughput, and the threshold, the cutoff, should be personalized. And this is very useful for the utilization in clinical practice. The disadvantage eventually is delay the results because the results are ready in 20 minutes or more if there are many samples to be analyzed. This is a picture from a recently published paper in which you can see the typical pattern of the so-called point-of-care testing, lateral flow, and you can see the type of pattern, and you can appreciate that sometimes it's not so easy to recognize the band. It's not so easy to say if the band is positive or still negative. What about the target of the diagnostic system, both for point of care and laboratory-based tests? As you can appreciate in this slide, there are today several laboratory-based tests, both in chemiluminescent or ELISA, and the targets are different. If we were looking to the SNIPE-MAGLUMI we are using commonly in our practice, the targets are both the S1, S2 spike protein and the nucleoprotein, and to detect both the IgM and the IgG specific antibody. For other diagnostic systems, for instance, Abbott architect system, the target is the nucleocapsid phosphoprotein that is more or less the same as for the Roche Cobas electrochemiluminescence assay. The nucleocapsid measuring total antibodies, in this case, is the target. For the diazorin liaison, is a recombinant S1, S2 spike protein, measuring only IgG. For another assay that is a diagnostic system, DS, ELISA, as you can see, they are using the native antigen. There are a typical line of cells infected with the SARS coronavirus 2. Fortunately, some months ago, this paper provided us a protocol for serological assay, antigen production, and test setup. And I invite you to carefully read this paper that should be used by the manufacturer, first of all, but also by laboratory professional to better understand the status of the art of serological tests. And this is a paper we have published with Professor Lippi on current laboratory diagnostics of coronavirus disease. And you can appreciate in this that we now know exactly the gene of the virus and the different target we can address the ELISA as well as the molecular testing. This is another more recently published paper in which you can appreciate the wild spike protein and particularly the receptor binding domain of the spike protein that is very important, and I will deal with this later on. You can appreciate that we know exactly the molecule, not only the molecule pattern, but even the different expression of this protein, and this is very useful to provide information to set up not only the antibodies but even the total ELISA or chemiluminescent assay. So this is very important to be understood. Some months ago, we had some knowledge gaps in serological tests because, as you can appreciate in this slide, the kinetics of antibodies, the so-called time frame, was not so clear. And we have other knowledge gaps on the level and duration of immunity. This is still not completely known. And therefore, the likelihood of protection against reinfection is still an open issue. And this is another reason to use a serological test to better understand the immunity and the immunity response to this new virus. What about the antibody kinetics? There are differences in the literature. We know the antibody targeting M protein and the RBD are the earliest to be detected, according to some references to some authors, in 100% of patients, at least 13 days after symptom onset. There are similar profiles described in the literature for anti-spike 2 antibody with a mean time lag of 2 days in comparison to the M protein and RBD, receptor binding domain. And finally, antibody targeting the S1 subunit seems to be the last to be detected. So not an early kinetics, a late kinetics using this type of target. This is one of the first paper published by K. Wong To in latent infection disease. You can appreciate in this slide the behavior of IgG and IgM having target the receptor binding domain. And according to this picture, IgM do not appear early than IgG in some patients. That is an unexpected issue. This is a more recently published picture in which you can appreciate the time frame of the antibody in comparison to the detection of RNA of the coronavirus 19. So there is no doubt the molecular test is an early message and detection time in comparison to the antibody. Second message, total antibodies, in this case provided by ELISA, but even by other chemiluminescent agents, appear early, and thereafter the IgM, and later on the IgG antibody does appear in this in the patients, in affected patients. So, summarizing, it seems that total antibodies appear a little bit before IgM and before, a little bit early, than IgG specific antibody. And you can appreciate the time frame in which you can see that only few patients present the antibody between 5 and 10 days. Much more patients present antibody after 10 days and between 10 to 15 days, and maintain the level of antibody later on. So the step to be performed when evaluating serological assay for COVID-19 disease are, first of all, to validate the analytical performances in precision, repeatability, dilution, and eventually recovery studies. Second, to understand the seroconversion time, the kinetics and the rate. Third, to better understand the diagnostic specificity and sensitivity of the assay, and much more interesting, the predictive positive and negative predictive value. And finally, the use of the test in epidemiological studies. And this is what we have done, starting from the evaluation of the first IVD chemiluminescent assay for SARS coronavirus 2, that is the Maglumi by Snibe. As you can see in this paper published in Clinical Chemistry Laboratory Medicine, you can appreciate the very, very nice repeatability and intermediate precision, with values lower than the maximum is 6% of imprecision, quite good. It was evaluated according to the traditional recommendation by the Clinical Laboratory Standardization Institute. Here you can appreciate the linearity, the study of linearity, which demonstrates a very, very good linearity of both IgM and IgG as measured by Maglumi. And the recovery results in percentage are quite good. So from our point of view, this means that the Maglumi-Snibe should be defined a quantitative, not only qualitative method for measuring specific antibody for coronavirus 19 disease. And thereafter, we have evaluated the kinetics. And you can appreciate in green the kinetics of IgG, and in blue the kinetics of IgM. As you can appreciate, in some patients, they are starting 6 to 8 days after symptoms. And in this case, the symptom was fever, the first symptom. And IgG are maintained for a long time, while there is a decrease of IgM after 18, 19 days. You can better appreciate the kinetics in this table a descriptive statistics of the kinetics, in which you can see that between 12 to 13 days, 100% of subjects or patients developed IgG antibodies, detectable IgG antibodies, while the IgM were present in more or less 80% of the patients. In this paper, another paper, we have evaluated the IgA antibody with a test measuring the spike glycoprotein of the coronavirus. You can appreciate in this spaghetti plot the behavior of the IgA on the left and the IgM on the right side to better understand the kinetics of the different specific antibodies. And you can better see in this slide the kinetics of IgA, which seem to be to give us an earlier indicator than IgM, and they are